conversation on IBD testing, options for the present and the future. My name is Elisa Strauss. I am the Senior Manager for Adult Ed and Resources at the Crohn's and Colitis Foundation, and I'm happy to be moderating this conversation tonight. As you know, getting the right diagnosis may take time, and it's important to really understand all the testing options that you may experience during the diagnostic process. Additionally, it's important to be aware there is an emerging area of IBD testing known as prognostic testing, which can help predict whether you may experience a mild or severe case of IBD, or if you're likely to develop complications down the road. So I hope tonight's conversation will help us better understand all of our IBD testing options. I'd like to start by thanking Takeda for sponsoring this program, and I have the pleasure now of introducing our presenters. So tonight we will be joined by Dr. Elisa Boden. She's an adult gastroenterologist who's an assistant professor of medicine at the Oregon Health and Science University in Portland, Oregon. Dr. Boden serves on the Foundation's National Scientific Advisory Committee as co-chair of our Patient Education Committee. And I'm also here tonight to introduce to you one of my colleagues, Dr. Gerard Honig. Dr. Honig is the Director of Research Innovation at the Crohn's and Colitis Foundation. So thank you, Dr. Boden, Dr. Honig, for being here tonight.
Thank you.
You're welcome. So before we get started, I just wanted to go over a few quick pieces of housekeeping. The information that is provided during tonight's chat is meant for educational purposes only. It should not replace any advice you receive from your gastroenterologist or your primary care provider. If you do have questions about your specific care, please reach out to your healthcare provider directly. If you do have questions about IBD unrelated to diagnostic or prognostic IBD testing, we won't be able to get to them tonight. To get your questions answered, please contact our IBD Help Center. You can call them at 1-888-MY-GUT-PAIN or email at info@crohnscolitisfoundation.org. With all that said, let's get started. So Dr. Boden, we'll start with you. When we think about IBD testing and talk about testing, we know there are two different types of tests. There's diagnostic tests and prognostic tests. Can you start just by giving us an intro and explaining the difference between the two types?
Absolutely, Elisa. So diagnostic tests are medical tests that help us to figure out whether someone has a diagnosis. So if they come in with a symptom, we do testing to see where that symptom is coming from and to help give them a diagnosis. Prognostic testing, on the other hand, really helps us to predict whether an event will happen in the future once we've already made a diagnosis. So, for example, prognostic tests can be designed to predict whether a patient will have a serious complication related to their disease or whether they might require surgery over time. But prognostic tests can also be developed to predict whether a certain medication will work for a particular patient or whether a patient might have an adverse reaction, a bad reaction to a medicine.
Thanks. So as far as diagnostic tests go, can you share with us some common diagnostic tests that a patient may receive when they're trying to determine if they have IBD?
Yeah, so there are a number of tests that can be performed to help us to know whether a patient has inflammatory bowel disease. So one thing we often start with is blood tests that can look for elevated markers of inflammation or low blood counts, anemia. We can also do stool tests that look for inflammation in the stool and that help us to rule out whether the patient might have an infection causing their symptoms. And then there are other testing like imaging tests like MRI or CT scan that can show us whether there's thickening of the bowel or narrowings in the bowel that can be suggestive of inflammatory bowel disease. But really the gold standard for making the diagnosis is with an endoscopy or colonoscopy. And the reason that's so important is that it allows us to get tissue biopsies that we can look at under the microscope. And these give us the characteristic pattern of inflammation that we see in inflammatory bowel disease.
So if a patient's experiencing symptoms and going through these tests, how long might it take for a patient to reach a diagnosis?
Yeah, that's a really, really great question. So, lots of studies have shown that the diagnosis of inflammatory bowel disease can often be delayed. And I think this is really especially true for Crohn's disease because most patients with ulcerative colitis present with rectal bleeding as one of their first symptoms. And this is something that usually gets the attention of their doctors. Whereas in Crohn's disease, although some people may have rectal bleeding, the symptoms can often be more subtle or can be confused with other things. So several studies have suggested in Crohn's disease that up to 20% of patients may have their diagnosis delayed for over a year from the time of their symptoms. And I think unfortunately we're seeing that even more with in the era of COVID, where it can be really hard for patients to get in to see their providers, especially specialists, if they're not having an emergency. But I also think sometimes, even when people do see a specialist right away and have a thorough workup, it can be hard to diagnose IBD. And that is related sometimes to the nature of the disease, which can come and go. The symptoms can ebb and flow. And if you had symptoms and then you're not having symptoms by the time you get to the doctor, sometimes the signs can be difficult to catch. And some people also have disease that's in a place that's hard for us to see or reach with our tools. And so that can also make it hard for us to diagnose.
And how do you prepare your patients for their journey once they do get that diagnosis? Are there specific resources that may be helpful?
Yeah, I mean, I think when I first give a patient a diagnosis, I usually explain to them why we think patients get inflammatory bowel disease. I think a lot of people worry that they got this disease through some fault of their own, like they weren't eating the right thing or they were too stressed out. And I first of all reassure them that that isn't the case. And we don't understand what exactly causes IBD, but it's a combination of genetic factors and environmental triggers, and it's never the fault of the patient. And while there's not a cure for inflammatory bowel disease, and many patients will require lifelong care and monitoring, we have very, very good treatments available. And I think the most important thing that they can do for themselves is to educate themselves about the disease and really become an active participant in their own care. And that means really learning as much as they can about Crohn's and colitis. And that's, I think, a great place where the Crohn's and Colitis Foundation can be a major support for patients, because we have so many education about all things IBD on the website through virtual and live events such as this one, as well as programs that provide social and emotional support for people that are recently diagnosed, because it can be quite overwhelming.
Thank you. All right, Dr. Honig, I'm going to switch over to you. So let's talk a little bit now about prognostic testing. So why would a patient want to look ahead into the future? How could that be helpful to them on this disease journey?
Sure. So I think Dr. Boden really nicely highlighted some of the possible applications, but in inflammatory bowel disease, we're fortunate that there are a number of treatment options, and these treatment options may require significant consideration and deliberation and discussion between a physician and a patient. And currently, it's not always possible to make a really clear distinction between different treatment options that may be available at a given time. For example, a patient may, at the time of initial diagnosis with Crohn's disease, that two patients may present quite similarly, versus one of them is likely to experience a significantly worse outcome than the other. One patient may go on first-line therapy, might go into remission for quite some time, may even eventually be able to go off of therapy and stay in remission for an extended period of time, versus another individual may experience multiple flares over the subsequent years and potentially require surgery in just a few years after initial diagnosis. So these are very, very different scenarios. And if with the benefit of hindsight, one might surmise that for a patient that is destined to have a more serious or more aggravated disease course, perhaps that patient, given the option and given that information, might have chosen a more aggressive course of therapy. And so it's not just choosing the course of therapy and also choosing the timing of the therapy, when a particular medication may be tried, when medications may be switched, even the choice of when surgery may be indicated. Prognostic testing can, in principle, provide useful information to support these various decisions. And these could include, for example, a patient with a sufficiently accurate test to indicate that the patient is likely to experience very frequent disease flaring may choose with their physician a more aggressive course of treatment. And then the ultimate, one of the ultimate goals of prognostic testing, which was also alluded to by Dr. Boden, might eventually be a test that could specifically indicate a higher or lower likelihood of response to a specific medication. Because in the IBD field, again, we're fortunate to have quite a few medications that are on the market, and all of them have advantages and potentially disadvantages, and all of them, unfortunately, still are associated with non-response or inadequate response in many patients who receive it. So the ultimate goal, and this is something which has been significantly advanced in a number of other disease areas, would be a molecular test that could support the choice of therapy by suggesting, and I think Dr. Boden can speak to this more expertly than me, for example, that a patient may have an inadequate response to a particular drug, for example, due to the formation of anti-drug antibodies, could also be considered a prognostic test. So taken together, prognostic testing could have the potential to support a precision medicine concept where patients can arrive to the optimal treatment paradigm earlier in their disease and have a better chance of achieving remission faster and more durably.
Thank you. So can you tell us just about these tests in general? How do they work? I know Dr. Boden shared with us a little bit about different types of diagnostic tests, blood tests and scans, but how do the prognostic tests work exactly?
Okay, so there are a variety of technologies that can be used to evaluate different biological processes in the body. If we focus on the, let's say, most advanced technologies within the IBD field that are being explored or advanced for the purpose of prognosis, they can fall into a few different categories. So some tests evaluate the body's immune responses to particular factors which may be present or elevated in IBD. Oftentimes these are reflected as antibodies against microbes. So microbes, of course, are present in the human gut, and in a normal, healthy state, for the most part, your immune system doesn't really overreact when exposed to these microbes. However, in patients with IBD, first of all, the microbial composition may be altered, and also the body's response to the microbes may be altered, and so that can sometimes be translated into the presence of antibodies within the blood against microbial factors that are typically not present or rarely present in healthy individuals. So that's one type of test which has been used for many years and studied in many immune diseases, but especially Crohn's disease. Another category of test, which is more recently introduced, has to do with studying the expression of genes in the immune system. So the immune system is composed of many different types of cells, and certain patterns of activity within particular types of cells, particularly T cells, can be, in some cases, reliably associated with a state of the immune system that then can be associated and predict the course of the disease. So these are just two of the many technologies that have been explored and continue to be explored actively. But in general, it's really a very rapidly developing field of biomedical research broadly, and also especially in the IBD field, to look at different facets of the immune system using recently developed technologies that really allow us to have an unprecedented level of understanding of complex biological processes, which is required to really get a full picture assessment to tell us something important about complex diseases like inflammatory bowel diseases.
And are these tests typically used at one point in time in the patient's journey, or are they repeated multiple times? And if so, how often?
Yeah, so this is a very, very important question. And I think maybe I'll take a step back and just talk a little bit about how these types of tests are developed. And so in order to develop and validate, validation means to repeat and to demonstrate the robustness of a potential test. And a test is not really a test until it's been very, very well validated, meaning it's been shown to reliably and accurately perform in ideally multiple different groups of patients in different geographical sites and in conditions that will be representative of the way the test could be used in the real world. So this is a very high bar. These are very complex studies to do, and they take years because in order to make an association between a particular test that is run at diagnosis, for example, and what can happen in the next 1 year, 2 years, 3 years, you need to collect samples at the time of diagnosis, and then you need to carefully follow these patients for multiple years in order to then be able to basically look back in time and say, okay, within 3 years, 20% of patients experienced a severe exacerbation of the disease, 11% perhaps required surgery. So then you go back and look, okay, what was happening at the diagnosis that can then be predictive of what happened later. So these are complex studies to do, and they also require very significant commitment from clinical research networks and of course patients also who have to participate often for multiple years. So this is the way these types of studies are done. And so to get at the question you're asking, you really need to assess multiple time points, both from diagnosis, after diagnosis, and up until the point where a certain event can happen. And so in general, most of the studies that have been performed to validate a particular clinical test use a particular study design where all samples are collected at a particular point and assessments are made at a particular point. And in principle, that's the condition under which the test was validated. So now, but it's very tempting once a test is available to think, well, is it going to work later? Is it going to work earlier? And unfortunately, the answer is oftentimes we're not entirely sure. And so the best answer we can give is that it depends on the test and it depends on the specifics of the clinical study that was performed in order to validate that test. And the patients in whom the test is most likely to perform as reported are the patients where that condition is relatively close to the setting in which the study was conducted. So there are some tests, for example, the ones that look at antibodies in the blood, where there have been a range of different clinical studies looking at different points in the disease course, and it seems as if they potentially can provide information at different stages in disease. Versus, for example, some of the tests I talked about with gene expression, those are more complex tests, they're more expensive to perform, and they're newer. And so in general, for the most part, those studies that have been done have really been focused on samples that are collected at the time of diagnosis. And we don't yet know how robust or longitudinally stable those signals will be at other times in the disease course.
Okay, thank you. Dr. Boden, so thinking about prognostic testing, is this a standard of care? Is it common for patients to have a prognostic test?
Yeah, that's a great question, Alyssa. So we actually do have some prognostic testing that is used fairly routinely in inflammatory bowel disease. And these are tests that help us to predict whether patients are at risk for a bad reaction to a medication. So one example is that we always check for a genetic mutation that can increase the risk of low white blood cell count when we're starting patients on azathioprine or 6-MP, which are thiopurine medications. So that's a test we've been using for a long time and is a prognostic. There's also a new genetic test that I'm starting to use in my practice to predict who's at highest risk to develop rejection of anti-TNF medications like infliximab or adalimumab. That can make them stop working over time. And so these tests are really helpful because they can help us to reduce the risk of bad outcomes by by adjusting the way that we deliver these medications or avoiding to give these medications to patients who are at high risk. I think in terms of the type of prognostic testing that we've been talking about, that can predict the outcomes, whether patients will have a complicated disease course, we're still in a pretty early phase of using these. It's certainly not standard of care for all patients, but I do suspect that this type of testing will become standard of care over the next 5 to 10 years as we develop some more sophisticated tests and have more research about how we can best use these in our patients. Right now, there are 3 tests that are commercially available to predict disease course and risk of complication in Crohn's disease. So Prometheus has a Crohn's disease prognostic test, LabCorp has a test called IBDX, and Takeda has a test called CDPath. So these are the 3 ones available in this country. And I have to say, I'm not using these routinely in my practice, but I am starting to use them selectively in patients. So I think for patients who already have known aggressive disease symptoms or aggressive disease at the time of their diagnosis, I don't really feel like I need to use these tests because I already know what their disease course looks like at the very beginning. And so those patients, I'm not doing these tests in. But I think where this might be most helpful is in patients who have mild or moderate disease at the time of their diagnosis, because in those patients, it may be really helpful for us to know whether we can monitor things over time, especially if their symptoms are controlled, or whether we should be giving them early aggressive therapy to help limit any complications that might happen down the road if they're in that high risk category.
Thank you. And just as a follow-up to that, for the tests that are available, is it for all IBD patients or just, we mentioned Crohn's disease, is it just Crohn's disease?
Yeah, so the ones that are available are for Crohn's disease. We don't have any of these prognostic tests for ulcerative colitis at this time.
Okay, thank you. So Dr. Honig, I'm going to flip back to you. As far as the latest research that has been done on prognostic testing, can you share with us sort of what's coming down the pipeline?
Absolutely. So this is a very, very dynamic area of research, and so I'll just touch on a few outcomes. So there have been a number of, so as I mentioned, these development and validation of these tests require long-term observational studies where patients participate sometimes over many, many years, and ideally tracking the progression of the disease over time. So these are challenging studies to do. And so one of the most influential studies in this particular field is known as the Pediatric Risk Stratification study. This was a study of approximately 1,000 patients with pediatric Crohn's disease who were studied for between 3 and in some cases up to 8 years of participation at 28 sites in the US and Canada. And the specific objective of this study was, in fact, to identify clinical as well as biological factors that would predict complicated disease course in pediatric Crohn's disease. The study was initiated in 2008, as I said. Over 1,000 patients with Crohn's disease participated, as well as actually many patients who eventually turned out not to have Crohn's disease because, as Dr. Boden mentioned, the diagnosis is not necessarily immediately obvious. And so certainly many patients were enrolled based on suspected Crohn's disease, and it turned out later that they had other pathologies, other contributing factors that were explaining their symptoms. But the patients with Crohn's disease were the ones that were followed for an extensive period of time. So there were a number of very important insights that came out of the study. It's resulted in many papers. I'll just and to highlight just a few, the study was able to demonstrate a number of clinical factors that are associated with poor disease course. So we're talking mostly about testing, but as Dr. Boden can speak to, I'm sure much more eloquently than me, there are also clinical variables and clinical observations which also need to be taken into account and can also aid patients and clinicians in having a better understanding of the likely disease course. These can include the location of the disease, the age at the time of diagnosis, and other factors. But I'll just focus on the two outcomes from that study. One was published in 2017, and I will mention that the Crohn's and Colitis Foundation was the longtime supporter, and thanks to many stakeholders and supporters nationwide that we were able to really support a study that is really quite extended in time, really requires that perseverance, that staying power and commitment of the research, as well as volunteer community and the patients, of course, who participated. So in 2017, the academic consortium published in a leading medical journal a study focused on the expression of genes within the intestinal biopsy, and was able to demonstrate that particular patterns of gene expression are in fact associated with complicated disease course. So this is one very interesting study that has led to many further observations and really provided a proof of principle that the expression levels of genes could be quite informative. Then fast forward a number of years, I'll talk about another study another test in which we are currently supporting a clinical validation study within the United States. And this is also studying gene expression, but in this case, studying gene expression within immune cells of the blood. This is a concept that was developed at Cambridge University and is currently being developed by a UK-based diagnostics company. This and is currently being used clinically in certain European countries and is being evaluated within the United States. And so what this does, looks at gene expression in the blood. This can be used in both Crohn's disease or ulcerative colitis. It's intended for use in adult patients at the time of diagnosis, and essentially is able to, based on 2 independent cohort studies in the United Kingdom, is able to stratify patients between high and low risk of severe disease course in the subsequent 18 months. And that, as I said, those studies were all done in the United Kingdom, and we're currently supporting a study to evaluate this in the United States to see whether these genetic gene expression factors are also predictive within the more diverse American patient population. The other very important study that's ongoing with that test in the United Kingdom is, as a next stage for them, they're actually using the test and incorporating it within the choice of therapy in a randomized fashion. So essentially, they're taking a few hundred patients with inflammatory bowel disease in the United Kingdom, a little bit different than the United States. Typically, pretty much all patients follow a more standardized order of choice of therapy. We're starting with first-line therapy and then going to biologics. But one thing that we haven't talked too much is exactly how these types of tests could eventually in the long term be used to really optimize care and make therapeutic decisions. And so this is an interventional trial where the patients are actually randomized for different interventions. One, which is a more aggressive intervention where biologics are administered earlier, and one is a more conventional step-up paradigm where biologics are reserved only if adequate response is not achieved with first-line therapy. And so the goal of that study, which is really very innovative within the IBD field, although it's been done in other disease areas, is to really see where the use of this test can be used to improve outcomes by informing a choice of therapy within inflammatory bowel disease. And so we're expecting, the study has been both studies have been a little bit delayed with COVID, but they're making excellent progress. I think so the US study just has 100 patients enrolled, and in the UK, I think they're over 250 now. So very optimistic for readouts from both of those studies within the next 12 to 18 months. And then the last I'll mention, these are smaller studies that have been supported through the Foundation's investigator-initiated portfolio, but a number of very interesting studies showing that the particular patterns of bacteria present actually in mucosal biopsies. So these are not bacteria that are measured in fecal matter, which is also very important. Dr. Boden mentioned a number of fecal tests, so those are certainly can be important in a variety of settings. But here, what the investigators are doing is looking at gene expression within the actual bacteria that are essentially adhere to the intestinal wall. And they're looking at it specifically in the context of postoperative recurrence. So this is a situation which can be quite challenging. A number of patients can undergo surgery and be monitored with not too much further intervention and can do really well, versus others will experience rapid disease recurrence in relatively short time. And it turns out that the microbial composition at within the intestine, within the mucosa of the intestine, can in fact be used to predict with a reasonable degree of accuracy the likelihood of recurrence within 6 months following surgery. And this has been observed in 2 independent studies, one at KU Leuven in Belgium, and the second at currently wrapping up at Boston University as well. So these are just a few of the really exciting pieces of research that we are optimistic in the years to come will provide new and improved tools for clinicians like Dr. Boden.
Thank you, and thanks for capturing all that for us. We appreciate that. Dr. Boden, so taking all this into account, when it comes to all our testing options, whether it's a diagnostic test or possibly a prognostic test, what are some important questions a patient perhaps should ask their provider about testing and about regularly monitoring their disease?
Yeah, I just also wanted to say, Dr. Honig, that was so great and so much exciting things coming down the pipeline. I can't wait until we have these tests to use, because they're going to be so helpful for, getting our patients better outcomes and being able to treat people with a more, with more information about how what we do will help them. So thank you for that. So, I think, Elisa, can you repeat your question for me? Because I just had to say that, and now I want to make sure I'm answering the right thing.
Yeah. So I was saying, taking into account all the different types of tests that are available, whether it's determining your diagnosis or thinking about, things down the road, what are questions, if you're a patient, what are questions that you should be asking your doctor about getting regularly tested, testing options, and monitoring your disease?
Yeah, I mean, I think always when we're doing testing and monitoring, I think for these prognostic tests as well as for all the routine tests, we always want to be asking our physicians how the testing is going to help them change what they do to treat the patient, right? If we're doing tests, we want to know what information is that going to give us that's going to help us to make the next treatment decision. I think, this is really true for this prognostic testing, because we want to make sure that if your doctor is recommending it, or if you're thinking about, asking your doctor about it, you want to know how it's going to help you. Is it going to change the medicines that you're going to be taking? And if you get a specific result, like a high risk result or a low risk result, what does that mean for you? And I think it's really important to know how to interpret these tests, because even if you get a low risk for complication result, doesn't necessarily mean that you and your doctor are going to want to decide to not put you on any medications. It may still be important to put you on medications and continue you on medications for a lot of reasons. So again, I think whenever you're having testing done, it's really important to know how it's going to impact your treatment in the future. I think the other thing just to keep in mind with all of these tests, and I'm really acutely aware of this as a provider, is that a lot of this testing can be expensive. And it's not always covered by insurance. And so it's really important, whatever testing you're getting through inflammatory bowel disease care, that you just, before you get the test, that you check with your insurer or check with the test, the manufacturer of the test, to see if it's going to be covered, and if it's not going to be covered, if there are programs that the manufacturer may have that either reduce the cost coverage or cover the cost. And a lot of times, if the manufacturer does have programs, they have a specific place that they want you to get the testing, so you may not just be able to get it anywhere. So it is really important, if you do decide to get these tests for ongoing monitoring or predicting potentially the future course of disease, that you just make sure that you're not going to get stuck with a big bill.
Yeah, and I'll put a little plug in there that, the foundation website does have a section on our website under managing costs where you can search for, there are financial assistance programs available through the manufacturer, and we have a little database that you could search, for those tests to see, how to get that assistance. So I just wanted to put a little plug in there as well, because you're right, cost is a huge factor for many of us. Thank you. All right, Dr. Honig, I think you have our very last question of the evening to sort of, recap all that we've talked about tonight. The future for prognostic and diagnostic testing, where do you think the future holds for patients with IBD as far as testing goes?
Yeah, it's a great question, and I hope I've shared some of the really exciting research directions, and it gets more and more exciting every year. But as far as what the future holds, I just want to come back to the last question. So testing, it is expensive. There are challenges that can be encountered with many different types of testing, not just prognostic testing, with respect to whether it's covered by different insurers. And so what, and obviously there are many different factors that come into play there. But if you think of that from a research perspective, ultimately we need research evidence that can really demonstrate improved outcomes in a manner that is reasonably cost effective, because if a test, the cost of the test is one thing. Question is whether, as Dr. Boden has very eloquently put it, whether use of the test can actually impact the clinical decision making. Now, maybe that some patients would like to, use particular tests and talk to their doctors about it because, they feel that it gives them some added level of information, and they feel that they can, really understand in context what that information means. But at the end of the day, if we really want these tests to be as impactful as possible, we ultimately will need clinical research evidence that can actually show that they can are feasible. They can be feasibly implemented within different clinical care settings, that they can reliably provide information that physicians and patients can use in order to optimize their care. Ultimately, that has the potential to either, for example, reduce the occurrence of undesirable events such as adverse reactions to drugs, or improve sustained remission or deep remission, or any number of different positive and negative, improve positive outcomes and reduce negative outcomes. And then ultimately, if our goal is to convince payers that they should reimburse for these tests, there needs to be a healthcare economic argument as well to show that they can actually be that they're cost effective because, for example, they preclude hospitalization, reduce need for surgery, and really have other meaningful impact in terms of these very, very costly and, of course, outcomes also, of course, associated with a great deal of suffering as well. So if you look to the future, obviously we need even more precise technologies to study genes and proteins and microbes, and those are continue to get better and better from a technology perspective. We need, even more robust longitudinal observational clinical studies in which to ground this evidence and validate them. We need to study diverse populations, including populations that are historically underrepresented in research. That includes patients that live in underserved areas, that includes patients from a variety of different backgrounds, also includes patients with a variety of different clinical presentations. who are not sometimes not always offered the opportunity to participate in research studies. And then we need to really do this research in a setting where we can really understand the real world impact of these and really, really understand the practical aspects of how these tests can be integrated into clinical care in order to improve outcomes for patients.
Thank you. Thank you both. Thank you, Dr. Boden. Thank you, Dr. Honig, for taking the time to help us really better understand all of our options. Thank you to our sponsor, Takeda, for supporting this program. Thank you all for joining us at home. If you have further questions about IBD testing that were not answered tonight, please visit our foundation website at crohnscolitisfoundation.org. You can also contact our IBD Help Center by calling 1-888-MY-GUT-PAIN or emailing info@crohnscolitisfoundation.org. Thank you again and have a good night.